Can you hear me now? Good morning, good afternoon, good evening, everyone. You are all warmly welcome to this joint webinar between the Oculoplastic Sister Societies, e-soppers and app-soppers. My name is Eva Dalgård, and I am the president of e-soppers working in Stockholm, Sweden. I have the pleasure to organize this meeting together with Faisal Patel from Tehran, Iran, and Ganga Samba from Singapore, and Gustavo Savino from Rome, Italy. I will now hand over to Dongmei Li, who is the president of app-soppers in China.
Oh, sorry. Can you hear me? Okay. Good afternoon, all dear my friends, e-supper and AP-supper friends. As two sister society, we have previously collaborated, and our joint webinar have reached tremendous successful. On behalf of the AP-suppers, I welcome you to today's webinar. I hope you will enjoy and benefit from today's challenge cases. Thank you. Welcome.
Good day, everybody. It's a great pleasure to have stars today with us as faculties, and also we have a galaxy of stars in the audience. So we are very pleased to have you all with us for this great meeting today. So the program includes 4 sections and 1 keynote session. Each section takes like 30 minutes, and we have a keynote lecture between section 2 and 3 for 15 minutes. We will have Q&A. We have very interesting time for discussions and interactive, comments and discussions. So thank you very much for joining us. Ganga?
Thank you, Farzad. Handing over. And it's my pleasure to welcome you all to this challenging oculofacial case webinar series, which we've been organizing for the past several years. This was an experiment which started in the summer of 2020 when we were all into lockdown. A simple pilot project was very successful and great rewards. And you can see some of the doyens of oculoplastics then. That led to the very first ever partnership with AP-soppers and starting the first ever webinar in July 2020 when we managed to get far more faculty over the next several months. This led to the very first AP-soppers e-soppers webinar in February of 2021 last year, thinking that the COVID pandemic will be passing very fast, but you can see the expanding number of faculty, primarily based on the number of interests and the people logging in and the excellent feedback we were getting over the years, with the honor of interacting with Francesco and Dr. Dongmei Li at that point of time. And that eventually migrated towards an A-soppers and AP-soppers program. Both e-soppers and A-soppers have been collaborating with us over the years, and this was a pure aesthetic webinar at that point of time. And finally, it's my pleasure to welcome you to the 5th challenging oculofacial plastic program, where we are concentrating specifically on pediatric oculofacial cases. Thank you very much for all joining us, and we look forward to wonderful interaction. Thank you. Over to you, Gustavo.
Many thanks, Ganga. Warm welcome to all. I wish that this joint webinar will be a unique opportunity to meet and debate between experts from Asia, Pacific, and Europe. A special thanks to my fantastic co-organizer team, and hoping you will find it interesting and useful. Enjoy the webinar, and advise the participants can write their question for Q&A time for each section. And we shall now come to the first section, eyelid and socket disorder. I leave the word to Eva Kopp, chair of the section. Eva.
Thank you, Gustavo. So we'll have the clip, Eva, if you agree. Thank you very much.
Yeah.
So we'll see the clip. Ehsan.
I am an image.
Okay, thank you very much. We will now start section 1, dealing with the eyelid and socket disorders. Dong Mei Lee will moderate. By her side, she has Christoph Hinchich, former ESOPER secretary, Munich, Germany. The first case presenter is Milind Naik, Hyderabad, India. I'm not sure if he's available, but we have his case recorded. His case will be discussed by Francesco Carantaleone, Rome, Italy. Thereafter, Dion Patron from Amsterdam, Netherlands, will present a socket case, and her case will be debated by Sonny Shen, Singapore. So Dong Mei and Christoph, please.
Okay, thank you. Let's start our first session in this challenge case about eyelid and socket disorder. First speaker from Indian, Milind Naik, will give the pre-recorder. So please just show our pre-recorder. Just on fly.
Hello everyone, my name is Dr. Milind Naik and I'm an oculoplastic surgeon practicing at the L.V. Prasad Eye Institute in Hyderabad, India. It's a distinct honor and pleasure to be a part of this joint venture by the EPISOPRIS as well as the ESOPRIS, and I would like to thank Eva, Farzad, Ganga and Gustavo for putting this wonderful program together. Here we go with my challenging case. Ptosis and a bag of worms. I have no financial conflicts of interest. So we had a 15-year-old male who presented to us with ptosis since birth. There was gradual worsening and expansion of his right upper eyelid, eventually covering the entire eyeball. The current concern for him at this age was obviously cosmetic. His visual acuity was 20/40 in the right eye and 20/20 in the left eye. On the examination of the eyelid, there was an obvious horizontal as well as vertical expansion, and there was a classic bag of worms on palpation over the upper eyelid as well as the temporal region. The eyelid margin was thickened, which was more temporally than nasally. The ptosis was complete. There was excess posterior lamella. The eyeball otherwise was within normal limits. Left eye evaluation was unremarkable. We did an imaging and he was found to have orbitopalpebral neurofibromatosis and also a very small defect in the greater wing of the sphenoid. There was no proptosis. So the diagnosis for us was neurofibromatosis type 1 with severe ptosis, a plexiform NF involving the palpebral as well as the temporal area. The levator function was poor, which was recorded as 1 to 2 millimeters. For this patient, what we performed was a differential template technique where the anterior and posterior lamella were differentially excised, at the same time reattaching the levator to the tarsus. I shall now demonstrate the surgical technique on a different patient who was recorded recently. So we measured the palpebral fissure on the other side, marked it on the involved eyelid, and also marked the midpupillary plane. Then at 8 millimeters, we made our lid crease incision, and the rest of the tissue beyond the lateral canthal area was to be excised. We removed a small amount of upper eyelid excess skin to match it to the other eye so that we get equal amount of vertical height of the eyelid. We then filled the anatomy with Klein solution to reduce bleeding. The excess lateral part was excised with the rest of the eyelid. First, we fixed the lateral canthus, and then we differentially excised the anterior as well as the posterior lamella to match it to the other eye. At the same time, the levator was reattached to the tarsus with 3 interrupted 6/0 Vicryl sutures. There was a moderate opening of the eye on table as we completed the surgery. The rest of the skin was then draped in place and the temporal component was closed. So here are the post-operative pictures of our patient. You can see on the left panel, it's day 1 post-surgery, week 1, and then at 2 months. Eye closure was good, and we had very minimal lag of thalamus, which was functionally stable. So the learning points for me, that severe ptosis in neurofibromatosis 1, a single stage correction is possible where you may have to differentially excise the lamellae. Here are some of the examples of similarly treated patients before and after a differential template technique with a single stage procedure. Thank you very much.
Very excellent. So next we will move to the give the comment, Professor Francisco.
Okay, good morning to all of you, to all the participants from a sunny and hot Rome. Can you hear me and see me? And see my presentation all right?
Yeah, okay.
Thank you very much. So I'll go on. So there are some very interesting learning points from what Milind showed to us. So we know it's a neurofibromatosis. We always have this severe ptosis. We had eyelid hypertrophy. And sometimes this very floppy eyelid is overlooked. And sometimes we have squint as well. And what is uncertain is when we end to operate, because most of the times the rate and extent of growth of tumors may be unpredictable. And we all know the neurofibromas, unfortunately, may progress, and patients should be warned that surgery may be needed at a later stage. So what is very important that Milind showed us is this single stage correction, which I like very much. I'm always a supporter of a single stage correction in any oculoplastic case, if that's a possibility. But I have a couple of questions for Milind. So, I mean, we can ask the questions to the participants or to the hosts of the meeting. So what is the real advantage of the separate resection of anterior and posterior lamellae, and how do you reposition the lateral canthus? This should be a little bit clearer to me. And I can show a recent case of a guy who is 14, and you see the postoperative picture at 1 week. So in this case, we did, of course, the lid shortening. So it was a direct shortening with a big pentagon excision. At the same time, we advanced the levator. and we did the debulking of the neurofibromas. And of course, we didn't touch the eye. This poor guy had several operations for glaucoma. The eye is hypotropic. So this is the final level of the lid. And again, my second question here is how to judge the amount of levator resection during the procedure, because most of these children or young eye, usually I try to operate people in between 12 and 20 at the most. Usually when we test these children or these guys preoperatively, we see that there is a poor levator function, but then when we operate, it's not that difficult to find an hypercorrection, which we saw in some of Millen's cases. And you see what happens. I'm a fan of a single stage correction. So in this girl, we did at the same time the ptosis, the lid shortening, the reposition of the lateral canthus through the skin crease, a partial debulking, and at the same time, a left medial rectus recession. And you see the result is not bad, but with and without glasses, now she prefers the left eye. We propose a right medial rectus recession at the same time, but the parents didn't accept to operate on the good eye, so she might have it later. So basically, these are my two questions. I thank Milene for a great case presentation, more than one case, and I'd like to ask the moderators to answer my questions about levator resection and separate lamellae excision. Thank you very much.
Thank you, Professor Francisco. Millian on the flight, we just received his message. Millian on the flight. I like to answer the several questions. It's a really challenge. It's a very tough case, neurofibromatosis. Just as Francisco said, we used to give the general anesthesia, so we cannot judge the ptosis, the height of the papilla. So for my case, I just make the levator recession, just the white ligament, just a rich white ligament. And if the levator function is so bad, just use frontalis. And for the lateral canthoplasty, I like to do some suspension, like the perorbit. I would like to use the facial lateral to fix the lateral canthoplasty, to do the lateral canthoplasty. But Millian's procedure very excellent. So that's my comment. Thank you.
Can I make a very, very quick and short comment?
Yeah.
Yeah, sure. That's one additional, just to be to support what Francesco said and what you also, Dogma, you said. We recently did a genomic research on a large population of children with neurofibromatosis, and then we found that the pattern of the oculofacial neurofibromatosis is different from the general. And unfortunately, it looks to be much more aggressive in terms of genetical modification, genes that are mutated. And as a clinician, we all know that unfortunately those cases also in the first operation, they are very well corrected. After 1 year, 2 years, they have recurrence of the ptosis with the regrow, and the regrow is very difficult to treat. So I definitely support these guidelines to try in the first operation to do and to resect as much as you can, because the second resection will be much more difficult.
Thank you.
Thank you. Yeah. Another comment?
I would like to comment as well. I think the amount of resection of the levator really depends on the amount of horizontal laxity correction. If you take out a lot of horizontal tissue, you need less resection. If you do the normal resection you would do in a patient without any laxity, you would get an overcorrection like we saw in one example. So this is important as well. If you have a levator function of 7 millimeters, you know that the position of the upper eyelid that you get on the table in a patient in general anesthesia will be the eventual outcome. But if there is more laxity, it will be higher. So this is something to look at.
Yes, can I just say a final comment? I mean, we all know that when we in an adult, we try to correct ptosis and upper lid laxity in a floppy eyelid syndrome that is very difficult, very challenging to have a good result in one go. Still, I mean, I find that all the neurofibromatosis cases very, very difficult to manage, but the only thing that it's not very difficult, in my opinion, is the high level. So it's the height of the upper lid. That I would suggest not to be very aggressive. I mean, it doesn't, I mean, of course, it's related to the bulking of tissues, to upper lid laxity, how much you cut from the lid. But in the end of the day, I would suggest not to be very aggressive with levator resection, because in the end, the upper lid level is not bad. Jeff wants to.
I think one of the troubles is assessing levator function in children with plexiform neurofibroma is effectively impossible preoperatively. And during surgery, you'll often find the levator is spongy, poor quality, infiltrated by neurofibroma itself. And also the tarsal plate, even the part you keep, is often poor quality. And so predicting the final levator, you know, how much to resect, it's really a matter of trying to fix what is there onto what is available. And you may well have to adjust it later on, and the patient needs to know that it's a very second best. And that is key. You know, you can't get a good guide beforehand or even during surgery. But thank you for the cases, Mylind.
Yeah, I'm sorry.
Okay, at time, yeah. Aaron.
No,
please, Aaron.
I was just saying, I'm sorry, we could probably talk about this for hours because it's such a difficult disease. But I'm sorry, we have to go on to the next.
Yeah. I just want to say we have to move to the next case. So please, Christoph.
Yeah. Hello.
Dr. Christoph.
Hello.
Yeah.
Thank you. So next case, very shortly, we're going to have the presentation of and she's going to show us how to treat the also not very easy case of congenital anophthalmos. Particularly, this is more a congenital microphthalmos, and we will see that clip and discuss it. Thank you. Hello?
Thanks to the organizers, my name is Dionne Hartong. I have no conflicts of interest. This case is about a boy born at 38 weeks of gestation. At examination, there was no visible eye on the right side, but otherwise there were no abnormalities on his general exam. At clinical examination of the eye, we saw an inward rotation of the superior and inferior eyelids, and the eyelids were much smaller compared to the other side, with 10 versus 17 millimeters. And with stretching of the eyelids, a deep, smaller cyst-like structure was visible. The ultrasonogram confirmed the small eye remnant on the right side, and the left side had a normal axial length and no structural abnormalities. The diagnosis is thus a severe unilateral microphthalmia on the right side with microblepharon. Since there is no visual potential, the goal is aimed at the cosmetics, where the sockets and the eyelid should be expanded in order to fit an adequately sized prosthesis. We do this with gradually increasing size conformers, and we started to do this with 3D planning and printing in order to have a better control of the sizing and to save production time. In the superior picture, you see an example of increasing size conformers in the case of total anophthalmia. In the case of an ocular remnant, you can shave off the posterior part to put over the ocular remnant. Most children receive a diagnostic MRI at about 3 months of age, and we use this opportunity to make a socket impression and to segment the orbital structures to design a better fitted ocular conformer. The impression is scanned and digitalized, and images are fused in a 3D modeling program. The ocularist designs the conformer with the aim to stretch the fornices. Not one, but more increasing size conformers are designed and printed to use as subsequent conformers. The fornices are also gradually changed in a shape to finally fit a regular prosthesis. The prints are shown on the left, and they should of course be grinned and polished before use. The process is continued until a symmetric eyelid size is achieved, and in most cases this is after 9 months, and then a regular prosthesis is placed. Debris and crusts occur frequently. They may be improved with antibiotics, low-dose steroids, or vitamin A ointment. Also, as in our case, a drawback can occur after a superficial infection. This means that suddenly the prosthesis did not fit anymore, and old conformers can then be used and upscaled, and usually the situation is back to the latest size after a few weeks. Other cases may show entropion, a lack of lid crease, or abnormal brow, which are not corrected with only a non-surgical conformer treatment. Learning points are, we should not be afraid of drawbacks, and also it may be questions whether it's needed to fully correct the orbital dimensions. While the orbital height and width were not fully corrected, the eyelid showed 100% symmetry with good cosmetic outcome. Some questions for the panel discussions are, what treatment would the panel have done in this case? How would you treat the crusting situation? And how would you correct entropion if it were present? Thank you.
So we can move on to the discussion.
Good afternoon. I'm going to discuss the case of congenital microphthalmia. I have no conflict of interest, and I congratulate Dr. Hartons and teams have fantastic clinical outcome in the management of severe microphthalmia. They highlighted the importance of finding out the axial length as well as horizontal palpebral aperture, which is easily two measurable clinical parameters for monitoring progress. They also showed the detailed management plans with the solid-shaped conformer. They emphasized the importance of starting early as well as soon as possible, and put the importance of frequent upsizings of the conformer until desirable results. Also, the 3D printing is a novel technique because all the information is staying in computers and have been digitized. It's time-saving, reproducible, and easily expandable as well as modifiable. We all know that congenital microphthalmia and anophthalmia is a difficult conditions to manage. The management of it is always time-sensitive. We have to worry about globe development as well as visions, as well as orbital development, and therefore the facial asymmetry. Particularly, sometimes when cases presented late, we also have to manage the patient's expectations because the management may not be easily tolerable or acceptable by our patients. Not to mention, we have to cover the associated medical conditions as well as the impact of genetic testing in today's world. As for the socket expansions, prior to the COVID lockdown, we have the opportunity to use a silicon hydrogel socket expander. It is another form because of expander, because in its anhydrous form, it can easily fit into a small socket. However, now because of the global supply chain problem, we might have to switch back to use the solid shade conformer. In terms of expansions, Dr. Hartons have demonstrated very well with the socket conformer. She can expand both the height as well as the width, but not to forget that the orbits and the facial developments also improve the depth dimensions. And as you can see in a simple equations, if you are short of just 10% in each dimensions, your total volumes is actually close to 30% shortage. For me, my solutions is we use the silicon hydrogel pin expander to expand the orbit. With the orbit also expanded with adequate volume, we will have a much better forehead as well as cheek projections, and correcting or bringing more symmetry to the facial differences, facial size differences, as well as a better brow ridge development, which Dr. Harton have mentioned that for the brow development is an important point that she wants to emphasize. For the crusting, I divided into two phases. One is the expensive phase where the conformer is changed every 2 weekly to 3 weekly during the infancy period. During this period of time, the management of a child is easier. We can practice frequently hygiene, use a bit of topical antibiotic eye drops, as well as lubrications. Don't forget the effect of dryness and mucus drying will cause more problem. If we have adequate lubrications, the crusting and the drying will be more easy to control. Then we have the second phase when the child already achieve a desirable size socket. That will be also means the child is in an older age group when they are toddler. Frequent applications of eye drops may not be that easy, or frequently hygiene may not be that easy. So we also rope in the help of our ocularists to have regular polishings of the prosthesis to make sure that they have no scratches and fissures and allow biofilm development. And in terms of the associated entropions in congenital sockets, I would like to believe that it's a little bit due to insufficient conjunctival lining. I'm a little bit against of surgery because of subsequent scarring and secretion changes. And as mentioned by our previous expert discussion panel, the more the surgery, the more scarring you bring into the play field. So I would boldly like to suggest that maybe after reaching a desirable size of the socket, we temporarily oversizing our conformer to see if the socket can be stretched a little bit further. If we have a little bit more soft conjunctival lining, we can do a simple either lead stabilizing or everting sutures technique to allow the posterior lamella and the anterior lamella mismatch to be matched. And for the absence of the lead crease, once the socket is easily corrected, the lead crease, we can even do a simple everting or anterior lamellar repositioning sutures or incisions along the upper lid, both creating the lead crease as well as correcting for the lash ptosis or phenomenon. Thank you very much for your attention.
Hello.
Iva?
Yeah. Thank you. That was a wonderful result on a difficult topic. However, there's something we should consider. There is a big difference whether we are talking about a microphthalmos or a real anophthalmos. This was a microphthalmos, and it was nicely done with that conservative approach. And what was very new and elegant here was that way of producing the 3D prints. This is something which is new, and obviously it is very helpful. Many of us are, as also discussed before, more for the conservative approach. in order to avoid scarring. And this is the same way we all have been trying to avoid. However, I would like also to discuss whether in some cases, and you all know there are these V-shaped, deep sockets with sometimes relatively shallow fornices. It is very difficult to fit a proper prosthesis than to larger. And the larger you make, the more inflammation you might get and scarring. This is one of the things where, and this is also in a new, Richard Collins described that many years ago and others, where one might consider some surgery, which is a dermofat graft, something dealing with these points. These are my comments regarding the upper eyelid entropium. This always sounds much easier than it finally is. Lower eyelid entropium, yes, we can deal with, but since the levator function is often very poor, we get usually, or at least ourselves, we don't get a long-standing good lid crease, which sometimes makes it a bit difficult for the patients in order to accept the symmetry or not real symmetry in these results. Is Dion, is she around, or
hello?
Are there any? Yes. Yeah. Hello.
I like to comment. We in our group we also included the total anophthalmia, that's when we start a little bit different, like I showed. And we also managed to get a wider, like horizontal palpebral length more than 80%. But I could only show one case here. But it is possible to also do that with this technique, with the total anophthalmia.
I like to say something. I have done the lot of the congenital microsomia. Use the self-expansion hydrogel. But now we heard the news from Germany. There are no product anymore. So I don't know in the future what we can do. But I use the semi-spherical hydrogel to expand conjunctival. And then maybe after the 1 year after the conjunctival expansion, the socket expansion, we may do the orbit expansion, use the spherical hydrogel. That's my experience for near the 20 years. And also we have to pay attention to the orbit development. And then we may change another step, just may change, replay the bigger the hydrogel, the spherical hydrogel, just like that. But this case, 3D print had a very excellent result. I think we may learn, we may change because there may no hydrogel product anymore. So we may learn and change this procedure. Thank you.
May I make a comment? I think this was a brilliant presentation, and it's a very exciting method. We've had a great deal of experience with the hydrogels and using dermis fat grafts for volume, which has also given us excellent surface. There's a difference between making an incision in the lateral canthus, which is a disaster, and doing something centrally when you can place in an implant that will grow with the size of it with the child. I will show a case later of that. We've done over 100 cases of this type with dermis fat grafts, but I think this new method holds great promise. The other comment is that one has to have an excellent ocularist and has to be able to have families that have the resources to travel to an ocularist from distances. And so one of the other advantages of the dermis fat grafting is that it allows for some motility when there are rectus muscles. It also allows for a thin prosthesis and doesn't give weight to stretch the lid tissues inferiorly. So I think it's wonderful that this new technique is offering us something, since we don't have hydrogels at the moment. although our laboratory at Children's Hospital in Philadelphia, we're working on this, but I think it's going to take a year or two before we can share that with everyone. Thank you.
So then I think that well, it is difficult and it wouldn't take more time for this. And I think I hand over to our president then.
Thank you. Thank you very much. To make this short, thank you so much for the excellent case presentation of the moderators and the discussions. So to sum up, in the neurofibroma case, well, a single-stage resection is very good if that can be done, but we have to be aware that this is probably it's difficult to do in one case. We should take as much as possible in the first surgery, and also what the difficulties in how much to take off of the levator, and the importance of the horizontal resection. And you don't need to resect so much of the levator. And going on to the socket case, this with the 3D printers might be something very good. As you say, that might be difficult for the children to come to it for someone who made the prosthesis. And also, my experience with the dermostat graft is really very good, and we know that will expand the orbit also after the conjunctival has been expanded as much as possible. So thank you so much. We end this section, and now I hand it over to section 2 with Farzad.
Thank you, Ipa. Great session, actually. I learned a lot from the session. So we'll move on to orbital inflammatory states. Actually, we have a very challenging situation here in terms of the systemic involvement, imaging, surgery. So we have two great moderators, Professor Piru Said, Professor Yuni Irovati. We have actually excellent colleagues presenting cases, Professor Hosyuk from South Korea and Professor Diego Estrenza from Italy. They will have discussions by Professor Dion Paridens and Professor Alan McNabb from Australia. So I would like to invite Professor Piru Said and Professor Yuni Irovati to start the section 2.
Thank you, Farzad, and thanks the organizing committee for inviting us. The first session was indeed a great session. I want to introduce Professor Hosyuk Sa from South Korea to present his case.
Ladies and gentlemen, I'm Hosyuk Sa from Asan Medical Center, Seoul, South Korea. It's my real honor to present a case at this wonderful meeting. Thanks again for giving me this opportunity. A 3-year-old boy presented with a diffuse erythematous swelling and complete ptosis of the right upper eyelid, which occurred 2 weeks ago. Due to the severe swelling, it was difficult to perform an ophthalmologic exam, and imaging studies were performed. CT scans showed an extensive irregular mass-like lesion with internal low density. The lesion was associated with an osteolytic change in the right frontal bone and needed differentiating it from tumor. There was no obvious intraorbital infiltration. MRIs revealed low signal intensity on T2, strong enhancement, and restricted diffusion, which suggested the possibility of preseptal abscess lesion. In addition, an irregular nodular lesion involving the left caudal nucleus was incidentally found. Actually, the patient had a long, complex medical history. He had recurrent infection since 50 days of age and was diagnosed with severe combined immunodeficiency, or SCID, And he suffered from disseminated skin lesions and also bone marrow infection, which were positive for AFB stain. And it was associated with previous BCG vaccination. BCG vaccination is being performed in most Asian countries and some European countries, and it is a live vaccine developed from Mycobacterium bovis. The patient took anti-TB medication for 21 months that successfully controlled BCG infection. However, after discontinuation, swelling lesions appeared on the upper eyelid and other areas. Based on medical history, clinical features, and imaging findings, BCG infection-induced preseptal cellulitis with abscess formation was suspected. We performed a percutaneous abscess drainage to remove pus, necrotic tissue, and debris as much as possible while preserving normal tissue. Massive irrigation with saline mixed with antibiotics was also conducted, and skin wound was closed with an observable suture. In addition, stereotactic aspiration of the brain abscess was also performed. The pathologic exam of eyelid specimens revealed granulomatous inflammation with abundant infiltration of macrophages and other inflammatory cells. An AFB stain showed thin red rod-like organisms, which was consistent with BCG infection. Anti-TB medication was started again and has been maintained. Currently, the patient has no evidence of infection or inflammation, and he is still on TB medication. These are photos after surgery. The scar and depression was severe at first, but then it got better and better. So in conclusion, clinicians should be aware that if BCG is accidentally given to an immunocompromised patient, it can cause disseminated or life-threatening infection, including periorbital infection. BCG pharmacovigilance and occurrence of suppurative complications should be well known by clinicians for correct identification and proper management. Thank you very much for your attention.
Thank you. This case will be discussed by Dion Paridans the next 4 minutes.
Ehsan, can you show Dr. Paridans' video? Ehsan, can you show Dr. Paridans' video? Okay, I may show the video.
Peruse, it was pre-recorded to save time, but
yes. Okay, honestly, while we're waiting, I had a question from Professor. Is in South Korea, is that mandatory, the BCG vaccine? Because in Europe,
that's right.
Yeah, and you do it twice, or?
Yeah, just one dose.
One dose. Yes.
Usually, it is inoculated within the 1 week of age. Yeah. So there is not much time to take a blood test to see if there is some kind of defect or deficiency of immune system.
So I see that presentation of Dion is now ready. We are going to listen to that first.
So
of this joint webinar for all their efforts and for inviting me to comment on the educational presentation by Professor Sa. Good day to all of you. I would like to first thank the organizers of this joint webinar for all their efforts and for inviting me to comment on the educational presentation by Professor Sa. Professor Sa nicely illustrated that vaccination with a live vaccine in an immune deficient child may have life-threatening complications. While BCG vaccination should not be given to patients with immune deficiencies such as SCID or HIV, it accidentally happens. Clinicians should therefore be aware of the potential complications of such live vaccination, including the clinical presentation when there is a problem afterwards. Tuberculosis is the deadliest human infection, killing 1.5 million people in 1 year alone. It is caused by Mycobacterium tuberculosis, and we have to note that BCG remains the only tuberculosis vaccine to confer protection in large-scale trials. Bacille Calmette-Guérin, named after inventors Albert Calmette and Camille Guérin, was first used in 1921. As of 2004, the vaccine is given to about 100 million children per year globally. In children, it prevents about 20% from getting infected, and among those who get infected, it protects 50% from devastating disease. The side effects or complications are more common and severe in patients with immune deficiency, often fatal. Mild side effects include injection site reactions and lymphadenopathy, which tends to be mild and self-limiting. Severe complications include osteomyelitis, subcutaneous abscess, arthritis, Reiter syndrome, mycotic aneurysms, endophthalmitis and uveitis. Some comments on the case presentation. The preseptal cellulitis and abscess formation, as was seen here in this case, in combination with brain abscess, is extremely rare following BCG. It represents disseminated disease in an immune deficient child. While subcutaneous abscess complicating BCG has been reported in the literature, this case presentation seems unreported. At least I couldn't find any literature with such case presentation. The previous medical history is very important for the diagnostic process, as was very well shown in this case. The differential diagnosis should theoretically not only include BCG systemic infection or tumor, such as benign or malignant tumor or inflammation-based tumors, for instance, Langerhans cell histiocytosis, but it should also include preseptal infection with abscess formation following eyelid skin infection, which would not be unlikely in a child with this syndrome. Less likely, one has to consider orbital trauma, for instance, by a wooden stick, accidentally or on purpose. That could also lead to orbital and also intracranial infection, but the anamnesis was probably not suggestive of that. Here is a scan of a patient of mine who developed such abscess following an accidental wooden stick intracranial trauma. Thank you very much indeed.
Thanks both for beautiful. Then Dr. Professor Saw can respond to comments of Dion.
Yeah, thank you for reviewing very important information about the infection related to BCG vaccination. So yeah, as he commented, this is a very rare case, but fortunately, I had enough information about the past medical history of this particular patient because he has been treated by the pediatrician in our hospital. But I thought without past medical history or other information, it might be very difficult to have a proper diagnosis in this kind of situation. So I thought the physicians should know that the vaccination would be very dangerous sometimes in patients with HIV or SCID or other types of immunodeficiency. Yeah, that's all I learned from this case. Thank you.
Yeah, sorry, can I will let you to talk now, Diego, but I want to say something that interestingly is also in the BCG is also used for treatment of some sort of cancer, like bladder cancer. I would say that the patients with cancer, they are immunodeficient in somehow, and they receive also that BCG vaccine with good result in bladder cancer, by the way. And so that is also a kind of interesting thing to be mentioned. Now, Diego.
Yes, thank you for your very interesting presentation. I just was wondering, since you said that the kids was affected with a severe combined immunodeficiency, which means that it's combination of, and you particularly said that was the X-linked type, because there are three subtypes of severe immunodeficiency, combined immunodeficiency. And particularly the type that you mentioned is the IL-2R deficiency. And this normally is a part of the neonatal screening, which includes the count of the T cell, because normally these children, they have lower T cell count. And so I was wondering how this was not built when the is not part of the regular screening, neonatal screening, in particularly, especially if you want to go for vaccination of the with the attenuated mycobacterium.
Yeah. I think that is very, very important comment. Especially, I don't have much information about that situation because the patients were referred to our hospital because of the repeated or recurrent infection already. So yeah, it is. I also agree that it is very important to have regular checkup, especially blood checkup, when they get birth, to see some defect of T cell or other lymphoid cells. So it could be very helpful to avoid this kind of unwanted infection related to vaccine, which is particularly live vaccine. So yeah, this is very unfortunate case, but honestly, I don't have much information about this particular case, but thank you for commenting that important thing.
Thank you. Thank you.
Any other questions? Professor, I see also in chats that Tim Sullivan is suggesting to write up this case as it is very interesting. So we have, these days we are also dealing with COVID and COVID vaccination. There are some, actually I saw lots of some case presentation, case reports about mRNA viruses like COVID and reactivation of autoimmune diseases, and like Graves' orbitopathy. there are some case reports that they report that after mRNA vaccination is also reactivation of the grape. So I think there are more studies necessary to report this. If there are no questions, we can continue with the next case, and I think then Professor Irabati will.
Thank you, Professor Prayut. I think shortly we have a second presentation from Professor Diego Strienes from Italy. He will be talking about the infection. I think it's a time. Please, Dr. Diego.
Hello, everyone. I'm Diego Strienes, and today we talk about fibrosis dysplasia mimicking orbital cellulitis. A 10-year-old boy was seen by us in a tertiary referral center, presenting with acute onset of painful swelling of the left periorbital area with redness of the skin and dropping of the upper eyelid. According to the parents, he had no trauma, cold, flu, or nose issues related. And there was also a kind of minimal improvement with the short course of oral antibiotics. This is the boy at first visit. Tenderness of the periocular area was obvious with redness and edema, limitation of the levator function. And actually, he didn't have many red flags, post-septal involvement. He had a mild production limitation, which might be considered a flag, but there was no visual impairment, no APD, no sign of uveitis or ocular inflammation. We were not able to take a swab because there was no evidence of discharge. Then the patient was commenced with IV cephalosporin, particularly ceftriaxone at maximum recommended dose, plus low dose of steroids. And he did quite well after 3 days with some kind of opening of the eyelid. And after 5 days, there was no further improvement. Then we decided to take a CT scan, and surprisingly, it was not only thickening of the eyelid and of the superficial tissues, but there was also a clear involvement, as you can see here, of the bone, of the lateral bone particularly. Here you can see also in this scan and in the bone window. And this is the coronal with supratemporal involvement, thickening of the bone. There was also, as you can see, a lack of the roof and the contiguous, maybe exposure of the dura with the possible threatening of the frontal lobe. And MRI did not add any further information. Then we decided to take biopsy or eventually specimen for culture if this is an infective process. But the result of the histopath was fibrosis dysplasia of the orbit. The kid improved after our intervention. Over the time, he had a complete recovery of the ocular motility and of the levator function, opening of the eye, also in terms of appearance. He had a satisfactory outcome. So bottom line is that orbital cellulitis in children, particularly preseptal, normally improve with the appropriate antibiotics regimens. But if not, there is a slow or partial response to the medical therapy. I do recommend to do imaging as soon as possible. And particularly if there is bone erosion, even if the patient seems to improve with medical therapy, I do recommend anyway to take biopsy. Second bottom line is that fibrosis dysplasia may vary in presenting symptoms, and although rarely it might mimic an orbital cellulitis, this was already reported in the literature too. I hope you enjoyed the lecture, and I wait for questions from the floor. Thank you.
Thank you, Professor Diego. I think we can hear now a discussion from Professor Alan McNabb from Australia. Please, Professor Alan McNabb.
Alan, please unmute. Alan, you are muted.
Dr. Alan, please. Your microphone open, please, Dr. Alan. We can hear your voice. Please unmute your microphone. The host, please.
Yeah,
okay,
perfect.
thank you.
Apologies.
It's okay. Please, Professor Alan.
Thank you. Thank you very much for inviting me to comment on this very interesting case that my good friend Diego has just demonstrated for you. And I'd like to just maybe focus on three issues that I thought might be worth discussing. The first is imaging in cases with suspected orbital cellulitis. Secondly, what role do steroids have in patients with confirmed or suspected orbital cellulitis? And thirdly, probably the most difficult aspect of cases like this is the exact diagnosis of fibro-osseous lesions. So firstly, should all children with presumed orbital cellulitis be imaged? And there are pros and cons for this, of course. The pros are that it does help in making the diagnosis. It might uncover unsuspected diagnoses, as occurred in this particular case. It might also reveal the presence of subperiosteal or orbital abscesses, which might require a different stream of management. And CT is, of course, much easier to obtain than MRI, but does have the disadvantage of radiation dose in growing children. Although with modern CT scanners, that dosage is significantly less than it used to be in years gone by. And secondly, what role do steroids have in orbital cellulitis? Now, there's been a couple of very good studies that have recently been published on this. This is the first one, published in a journal called Pediatrics last year, and it collected a very large amount of data from 51 centres across the United States, 5,500 children with orbital cellulitis, about a quarter of whom had been treated with corticosteroids, and they were able to show that there was really no benefit in terms of the length of hospital stay, whether the child needed to be admitted to intensive care, or whether surgical intervention was required. And in fact, steroids were associated with ICU admission and operative intervention within 2 days. So their recommendation was that before we adopt the use of routine steroids, there ought to be prospective randomized controlled trials. Now, a second study more recently, just this year, again, a very large multi-center study over many years, collected again about over 5,000 children. A much smaller proportion of those were treated with steroids. And again, they showed that there was really no association between having been treated with steroids or any benefit in terms of the length of hospital stay, the need for surgery or admission to intensive care, or to be readmitted to hospital for subsequent complications. And again, they recommended that the early use of systemic steroids should be discouraged outside of clinical trials. And the third issue, which I think is probably the most difficult of all, and that is the diagnosis of orbital fibro-osseous lesions. And I'd like to quote from Jack Rootman's second edition of his seminal textbook on diseases of the orbit when he was discussing this particular issue. And he said close cooperation is required between clinician, the radiologist, and the histopathologist, if you want to achieve an accurate diagnosis. And in many respects, the differentiation between dysplasias, osteomas, or reactive lesions may in fact be extremely difficult. This is the image from Diego's presentation of his axial CT scan. And there's a very useful review which was published in the European Journal of Radiology in 2014, which gathered together a very large group of experts from backgrounds in histopathology, from clinicians who look after bone diseases, and from radiologists. And they have very carefully looked through all the criteria for diagnosis of fibrous dysplasia and require that variable density be present, and that variability depends on the relative amounts of fibrosis and ossification, that a ground glass appearance is very typical in the affected bone, but also that there should never, in their words, be any soft tissue mass adjacent to the affected bone, and that CT and MRI are required, or both forms of imaging are required for diagnosis, particularly because CT scan will give very useful information on the appearance of the bone. So there is the suggestion on these images of Diego's case that there is in fact some soft tissue adjacent to the affected bone on the orbital side and possibly even on the dural side in the anterior cranial fossa in this young child. I agree that the bone does have a ground glass appearance in certain sections, but there are some features which might raise some red flags as to whether this is in fact fibrous dysplasia or not. Now, the paper that Diego quoted, where there was periorbital inflammation as part of the presenting features or as the clinical course of patients with craniofacial fibrous dysplasia, these are images from that particular paper. And you can see the variable density within the affected bones, which are much more widely involved than in the case of Diego. These are some of my own patients, and the blue arrows indicate those lower density areas that are often seen within fibrous dysplasia, as could be seen in Diego's case as well. So, is this really fibrous dysplasia? Well, I think that may be the case, but there are some questions to be raised. Other lesions can share some similarities. There's an example of a dermoid cyst in an anatomically very similar situation. I don't think that diagnosis would have necessarily been missed. On the bottom left, you can see a patient with Ewing's sarcoma, which again has some similarities in imaging features. And on the bottom right, a patient with Langerhans cell histiocytosis, with bony changes and soft tissue changes as well. So I think it might be worth continuing surveillance of a child such as this and try and keep an open mind as to the exact diagnosis. We need to be careful about the indiscriminate use of corticosteroids in patients with orbital cellulitis. But I confess that at our centre, we often use orbital cellulitis as well. We use steroids as well. And it's important, I think, also to obtain imaging early in the management of patients with orbital cellulitis. Thank you very much.
Thank you, Professor Alan McNabb. I think we all agree some of patients with the orbital tumor can come to us with the inflammation sign. And how about Dr. Diego opinion about the corticosteroid in inflammation case? And okay, I think Professor Gregor, yes, please.
Okay, thank you. First of all, I say thank you to be, this is a lucky day to have Alan as a counterpart, because Alan always puts on the discussion impressive thoughts, and thank you for that. So I will address all the three main points that Alan raised. The first one is about imaging. I will recommend definitely that when you don't see in the first 2 days in children, in the 48 hours, any remarkable improvement, go for imaging. Second, I'm not a big fan of the use of the steroid, honestly, because I have the feeling that they don't actually improve the outcome. They can make shorter, probably, but I'm not sure. The only key point is when the child presents a red flag, like red flag of orbital invasion. So then we have to go immediately for imaging, and we should consider only as if there is any visual acuity threatening. I think this is only the actual indication of steroids, but normally in this case, we just keep on giving steroids because he came to us that was already under steroids. That's why. But I'm not a big fan of use of steroids. And I would share with you only, fortunately, I didn't have intraoperative imaging, but that was interesting in this case. That to me was a big surprise. I remember that the fellow asked me to start because I think there was kind of drainage or mucus to drain. And she came and said, Dr. Diego, there's nothing to drain. So I came in your, I went a little bit further, and I find just a thickening of the bone that by using the curette, I took a piece out. So there was actually zero discharge, zero mucus, zero material to take for specimen for swab for bacterial investigation. There was only this inflamed, thickened bone that I took out with the curette. That was, and I agree that there was maybe something that we should consider when we say that fibrosis dysplasia can manifest without soft tissue involvement, because I see that, I mean, it's not high percentage, but there is a certain number of cases that present with soft tissue involvement.
Sorry, can I say something? Diego, when you say that at the time of surgery that you saw only the bone, actually in Langerhans histiocytosis, you might see a kind of blood-like thing that you have it in your suction. And another reason that might be Langerhans histiocytosis, as Alan said in your differential diagnosis, is also the complaints of patients were disappeared after the surgery. And it happens with Langerhans histiocytosis that even curettage of the lesion will create or will help to disappear the complaints. So I think that might be another thought, that this is also, or is a combination. If you have had a biopsy and you had clearly this fibrous dysplasia, so it can be maybe a combination. I don't know.
Yeah, I agree. I mean, honestly, the specimen was quite good and was thick. And was well seen by a good pathologist. That's that time I have cooperation with, and I agree. Maybe, but there was no evidence of histiocytosis. Honestly, we look at because that was my concern actually, and there was no evidence. And this was case of a couple of years ago. And the outcome was pretty stable. There was no recurrence or sign of progression of the disease.
Thank you. Thank you.
Yeah.
Thank you.
Thank you, Professor Gregory. I think Professor Gregory Ross, you have a comment about this case. You say there maybe there is any clinical sign of sarcomatous transformation in this case, Professor Gregory Ross.
Professor,
it's just really a comment across for not for discussion, that beware inflammation in an older person with fibrous dysplasia may be a clinical sign that you're getting sarcoma forming or infection in the bone. But I think probably you need to move on, don't you, Farzad?
Yeah.
Okay.
So we are running out of time. So if you and Piros agree, we can wrap up. So thank you very much. So I may just say words to wrap up this interesting actually session. we had 2 cases by our colleagues. So maybe I summarize a few quick points. In patients with actually immune deficiency state or relevant anatomic abnormalities or neoplastic disease, you may see atypical infections. So we should search for atypical microorganisms in such cases. And in these cases, we have a high probability for recurrence of the preorbital or orbital infections, and take serious every mild, even mild preorbital orbital signs in immune-compromised patients. So about the treatment of the BCG-induced orbital cellulitis, I may add that the standard of care for these patients is bone marrow transplantation. Am I audible?
Yes.
So thank you very much. We will continue the discussion in the panel discussion. I would like to move on to the keynote lecture. I would like to ask my dear colleague and friend, Ganga, to introduce the next speaker. Thank you very much.
Thank you, Farzad. Can you all see my slide?
Yes.
Yeah.
Great. It's my great honor and privilege to introduce Professor James Katowitz, who was universally acclaimed as the single keynote speaker to be invited to this wonderful pediatric oculoplastic webinar. Professor Katowitz, those of us who know him personally or through his books or his publications, is currently the director and professor emeritus of the oculoplastics and the orbital surgery unit of the Children's Hospital of Philadelphia. Having graduated from the University of Pennsylvania, kind of an Ivy League medical school, so to speak, he did his residency over there and went on a Fulbright fellowship to the Cornea Oculoplastic Surgery Fellowship at Queen Victoria Hospital, Sussex, and the Moorfields Eye Hospital. I'm sure that's where he probably got impregnated with novel ideas from the European side on the other side of the pond. And he had interacted with Mr. Rose and all the John Wrights and all the elder people in our society who have transformed the way we practice oculoplastics. And like a good scholar, he came back and did a second fellowship in pediatric ophthalmology, and he put them all together into what modern pediatric oculoplastic surgery is all about. My first interaction with him was after I had read his books once or twice or thrice. 2003 at a ESOPRESS meeting, I bought his book and had the honor and privilege of having him autograph the book that I bought from him, which is very dear to my personal collection. Since then, he's had numerous publications, and this is the latest edition of his book, the second edition of his book. And anybody who does anything related to pediatric oculoplastics, it's mandatory that we read all of his treatises. And this is an overview of the numerous chapters that he's covered, from basic sciences to translational to embryology to the cutting edge technology itself. He's had numerous awards. He's been the president of ESOPRESS. Most of us are member of it. He's received Orconstasia Leadership Award from ESOPRESS, the Wendell Hughes Award, which is a joint award given by both ESOPRESS and AAO, trained numerous, both ESOPRESS and international fellows. Some of them are outstanding leaders in our specialty in various parts of the world. On a lighter note, it is great and gratifying to meet him just a few months ago at Oculoplastic Today, organized by Guy Ben Simon in Jerusalem. Such a wonderful meeting. What I learned from him at that point of time is the warmth, the humility, how easily he shares his knowledge, and his wonderful wife, Carol Katowitz. And apart from the books, a great production of his is Bill Katowitz, who continues to increase the knowledge in the field of pediatric oculoplastic surgery. With us, let's give him a warm welcome to Dr. James Katowitz, our keynote lecturer today.
Thank you so much, Ganga, for your kind words. And thank you to the organizing committee for this extraordinary meeting. I'm just overwhelmed by the organization. And it's so wonderful to see so many old friends in this Zoom meeting, and hopefully some new ones as well. This topic was really suggested in some form by Ganga, and it was very stimulating for me to think about this. And I thought about some guiding principles that have been important to me in practice. Basically, number one, helping others, I think, is really a gift to us as physicians, giving structure and purpose to our lives. Education is a two-way street. It's important to learn from the questions of our registrars, fellows, and colleagues. Know your limitations. We can't fix everything. Poor genes and protoplasm are an unfortunate reality. Be kind and sensitive to patients and families, of course, but keep appropriate boundaries and be careful what you say. Don't promise results, just offer options and realities. I learned from one of my mentors, Abraham Werb, that mistakes will happen even with the best of plans. Accept this, but do not let the same thing ever happen again. Remember also that we treat a whole person, not just an anatomic part. Consider the psychosocial effects on a patient and the supporting role of family and friends. I did have a couple of surgical tips. One, be flexible, have a game plan, of course, but review it preoperatively and keep an open mind even while executing that plan. Another thing that I think is really critical, if something doesn't look right when you finish a procedure and you realize that an adjustment is going to definitely be needed, if there's no contraindication to fix it right then, do it. Don't take the easy way out and quit. That will only make continuing problems for the patient, family, and you as the surgeon. In thinking through innovations and contributions that team have made over these years, I highlighted some of these, but in the time permitting, I thought that I wanted to concentrate on one thing in particular, which basically has to do with dermis fat grafting and orbitofacial reconstruction. So we really can put this, there are really three categories for this, and I'll go through some examples of this, but I did want to say something about harvesting a dermis fat graft. We think the buttock is a particularly useful site in most patients, but it's critical when you outline this with methylene blue, not to just go ahead and dermabrade because you lose all your markings. So I think making some stab incisions and then proceeding really helps. The other thing is that you want to take a much larger circumference of fat with the dermis, because you can always excise excess fat, but you can't put it back when you need it there. Moving on to the first category of as a primary ocular implant, we talked about congenital microphthalmia a little bit this morning. And of course, there are many solid spheres, but the dermis fat graft, in our opinion, really is the ideal for an ocular implant, especially in these cases, because it provides volume in the orbit, increased lining for the socket, and in children, it will increase in size as the child grows. And I first learned this back in 1980 when I had a child presented here at birth with a microphthalmic eye. And we had at that time the first CT scan in Philadelphia, very primitive, but it did show this sphenoid wing defect in what we thought were intracranial cysts along with this abnormality. So at 6 weeks of age, I proceeded to remove the abnormal microphthalmic eye, and the cysts turned out to actually be orbital, not intracranial, and histology showed them to be teratomas of respiratory and gastrointestinal cells. I didn't know what to put in a 6-week-old for an implant with the sphenoid wing defect as well, and then I thought about the dermis fat graft, and so I managed to take a 12 millimeter implant. I don't know whether you can see it on the screen. I'm blocking it off with photos of all of us. But in any event, 9 months post-op, you can see the child doing well with a prosthetic shell. But here it is 18 years post-op. And if you look at the green line, that dermis fat graft had doubled in size. It's now 24 millimeters. And in terms of orbital growth, although these are two different methods of imaging, you can see the difference in asymmetry at 6 weeks and the relative symmetry at age 18 years from the dermis fat graft, as well as cosmetic conformers. So the role for dermis fat grafts in congenital microphthalmia, we touched on this a little bit earlier. I think the critical thing from our perspective is developing an adequate orbital space before placing in a dermis fat graft. The progressive conformer expansion and orbital expanders have been critical steps. And again, I thought the presentation this morning was extraordinary with the 3D printing and so forth. But in the past, our use of hydrogel osmotic expanders really was wonderful. Our goal is to create a space for an implant, and then we believe filling it with a dermis fat graft is useful, which it will grow in time, and we continue to enlarge prosthetic conformers. So this is just an example of a bilateral case at birth. And our technique was to avoid general anesthesia and to use a hydrogel osmotic expander in the clinic and seal with super glue the lids to allow 5 to 7 days of swelling without having that pop out. And here we can see the changes with a couple of exchanges of larger implants. And when there's enough space, we then can place in a dermis fat graft and again, use the conformers post-operatively. And here a child 10 months post-op bilateral grafts at about 2 years of age. Again, unfortunately, the hydrogel expanders are no longer available, but we're back to progressive conformer expansion. And I think the techniques showed this morning were an exciting innovation. Again, we're working on trying to develop a new osmotic hydrogel material, but we're a year or two away from being able to share that with everyone. The DFG is really useful when you have times there's too much orbital expansion, and then you need to remove the cyst and the abnormal eye at that time. And we can do that here with careful dissection with the aid of a cryoprobe. Then a large enough implant with fat to fill that large space, the graft put in the orbit, and the child doing well starting on conformers. Moving on to other forms of enucleation. Here's a child with ptysis, a very abnormal appearance, which affected his life. He was very unhappy and withdrawn. Putting in dermis fat grafts and shells allowed him to look more normal, and he was able to report to us the change in the way people related to him, which was a real benefit in his psychosocial development. Moving on to another form of initial primary use of a dermis fat graft. We looked at plexiform neurofibromas earlier this morning or today. And here's an example of a child who presented to us at 1 year of age. And at 18 months, we thought, oh, well, we need to debulk for amblyopia concerns and so forth. And he looks great at 4 months post-op. But as we've discussed earlier, these things keep growing. And here you can see the effect on the orbit, a huge orbit. And unfortunately, by 8 years of age, he was absolutely a terrible distortion. And the parents and our teams at Children's Hospital felt that we needed to move on and remove the eye, as well as putting in a large dermis fat graft to fill that volume. And here you can see a reasonable result post-operatively, which has changed his whole psychosocial development as well. Another primary use is in cicatricial problems such as this, an alkali burn with dermis fat graft, ocular pemphigoid with contraction. Again, that can be helpful in this fashion. Here's an interesting problem with post-radiation with entropion, as well as putting an implant in. This gives more surface and allowed the lashes to rotate without actual lid surgery. Another problem is in secondary implants. Here's exposure. Use of the graft, especially with dermis, can be effective with good blood supply. Here's a patient who had a successful integrated implant placed in another hospital 10 years prior to this time when it became infected and needed to be removed, and a dermis fat graft was quite successful in giving more volume and aligning. Moving on to complex socket problems. Infection, here's an interesting problem of noma. This is a parasitic infection that's common in the Black Sea area of Russia, causing necrosis with loss of the eye and lid tissues and so forth. So repairing this with a mid-forehead flap, dermis fat graft, and some additional mucous membrane gave a good result, as you can see 15 years post-op. Other kind of socket problems with post-radiation issues. When you have radiation, the use of some form of a blood supply, like a temporalis flap, can be useful to give a base with blood supply for successful dermis fat graft in this fashion. More complex forms can be with a combined team effect with a microsurgical team. Here, using a radial forearm flap for a radiation problem with contraction, giving a good result. For larger deficits, especially with soft tissue deficits, a scapular flap can be used, particularly in the Tessier 6, 7, 8 clefts, as shown here, giving volume to the cheeks on both sides. And here, with hemiphaomia, a good result, as you can see here, filling that defect. The last thing I want to talk about is the use of dermis fat grafts for lid-sparing exoneration. And as you know, this term is really a misnomer, as the procedure is usually performed, because all that is spared is the lid skin to assist in lining the orbit. The lashes, tarsus, and conjunctiva are unfortunately sacrificed. So this is the typical approach with stripping the periorbita and removing all of those contents. So if we were going to have a true lid-sparing exoneration, we would want to preserve the lid margin and conjunctiva. And when might this be an appropriate procedure? Well, this is a possible alternative in selected cases where tumor management is not compromised, and the dermis fat graft can then be used for orbital volume replacement. And essentially, what we're basically doing is doing a porotomy and moving around and stripping the entire periorbita and taking out the affected tumor. And then if there's been no radiation therapy, then the graft will be a primary take quite well. But temporalis muscle flap is useful if you've had radiation. So just a couple of examples. Here's a 3-month-old child with proptosis at birth. He was treated at another institution. The biopsy revealed it to be a caposiform hemangioendothelioma, and chemotherapy was given for 14 weeks with no response. He was then referred to our institution. And one thing that we all must always remember is always recheck the original pathology size, because with another look and different staining, a different diagnosis was found, and this turned out to be an infantile fibrosarcoma with a very different chemotherapy approach. Unfortunately, radiotherapy was not a treatment option, so debulking and their chemotherapy was done. The porotomy was done as I described. And here in this situation, preserving the lids, putting in a dermis fat graft, 16 months post-op. And here you can see the white fat growing quite well with a prosthesis above it, and the child doing well post-operatively. Obviously, having lids and looking more normal is of a huge importance in psychosocial development and welfare. And here she was 5 years post-op. The last case I want to show is this child who presented with a 3-day history of proptosis with edema. And on scan, you can see the arrows pointing to a retrobulbar mass. In this situation, I was able to remove just take off the medial rectus muscle and get a biopsy, which turned out to be a PNET tumor, a central neuroectodermal tumor. And in this instance, again, radiotherapy was not a treatment option. And this child went on to with chemotherapy. But here's an example of removing the entire tumor and orbit with exoneration, preserving the lids, tarsus, and conjunctiva. A large dermis fat graft put in place, and the child doing quite well post-operatively. Here you see 6 months with a prosthesis, 18 months post-op. You can see the fat, and here we are. At 2 years, doing quite well. And here, 3 years, a happy, well-adjusted child. Again, having lashes and lids and looking normal is a huge thing for a person's development and psychosocial benefit. And here, 5 years post-exoneration. So in summary, the dermis fat grafts are useful in orbitofacial reconstruction for a variety of congenital and acquired problems. The major advantage in children is the ability of this graft to grow with time, and it can be used as an ocular or periorbital implant, and is particularly valuable for lid and conjunctival sparing exoneration as an implant. So thank you so much again for the opportunity of sharing these thoughts, and this is a great honor for this extraordinary meeting.
Thanks very much, Dr. Katowitz. We are indeed honored that you could spend the time, woke up at 4 o'clock in the morning to deliver this beautiful oration for us. I have lots of questions, but we don't have the time. May I invite Mr. Rose to make a few comments, both about him as a person and his contributions to pediatric oculoplastics. Mr. Rose.
Thank you very much, Ganga, and it's a real honour to honour Jim, who, is a legend really in paediatric oculoplastics and has taught us so much and carries on teaching us so much. I think particularly your first slide, Jim, really brought home the whole of medicine and humanity, what medicine is about, and I think that probably is one of the most important things. Dermis fat grafts are great, and you've proven how well they work, but your first principles and so on is really the most important thing. And thank you very much for guiding us so, over so many years. So thank you, and thanks from everybody here.
Thank you.
In the interest of time, we'll move on, but we wish we will have Dr. Katowitz come back and now talk about each one of those bullets in the next several webinars that we'll be organizing the years to come. Thank you very much, Dr. Katowitz, once again.
Thank you,
I'd like to hand over to Dr. Gustavo Savino to lead the third session, please.
Yes, thank you very much, James Katowitz, for the wholesome lecture and also for joining us in a not very suitable for him timing. I'm very pleased now to introduce the section number 3, tumors, with 3 challenging cases. And the first case will be presented by Tim Sullivan, Australia, and discussed by Jeffrey Rose, UK. And the second case, case presenter is David Verity, UK, and unfortunately, Santosh Ovanar had an unforeseen issue, so will be replaced by Perot Saed and Jeffrey Rose. And the third case will be presented by Rachel Kalman and discussed by Yunter Yuan, China. And I'll hand over to the moderators, Ulrich Schodi, Germany, and Kyung-In Woo. And I will ask the moderators to keep track of time. Uli.
That will be actually very hard, I think, but we will try. And I hand over to my co-moderator, Kyung-In Woo, to start the first presentation by Tim Sullivan.
Thank you. My name is Kyung-In Woo from Korea. The first talk will be malignant pediatric orbital tumor, which will be delivered by Dr. Tim Sullivan from Australia.
I would like to thank the organizers, Dr. Kopp, Pactel, Sundar, and Savino for inviting me to speak on a malignant pediatric orbital tumor as part of this symposium on pediatric oculofacial plastic surgery. I'd like to present a 6.5-year-old girl who had left proptosis with a reddish mass seeming to arise from the conjunctiva, which showed a multilobulated pattern on the MRI. Biopsy of this showed some loosely dispersed pleomorphic spindle cells on H&E with no specific architecture or differentiation and few mitoses, but abundant apoptosis. Immunohistochemistry was strongly positive for muscle markers, negative for epithelial and lymphoid markers, and the FISH excluded an alveolar process. So it turned out that she had an embryonal rhabdomyosarcoma of the botryoid type with the red protrusion of her conjunctiva. This fell into a stage 1 group 3 and was treated with the low-risk Children's Oncology Group protocol and the ARST 331 radiotherapy protocol. She received vincristine, actinomycin, and cyclophosphamide in various cycles, and subsequently had 50.4 Gray of 3D conformal radiotherapy. And she actually had a very good response, but she had some residual disease, with her MRI showing a residual mass, which was FDG avid on subsequent PET. Here we can see the post-treatment MRI at 12 weeks with significantly rectus on the left. The question is this non-malignant scaffold or active tumour. A recent study has shown that about a third of treated rhabdos have some residual disease, and the majority of these will resolve or remain stable over many months, with a recommendation to perform serial imaging plus or minus PETs to monitor activity without needing treatment if there is no progression. However, ours did progress, and this is the subsequent post-treatment MRI where that residual mass enlarged and had significant FDG avidity. This was treated with further chemo and only had a partial response, after which the oncologists were worried about active tumour and discussed exenteration with the parents and child. So we were called on to do this. So we performed a lid-sparing total exenteration, with the defect being filled by a temporoparietal fascial flap based on the superficial temporal artery, and that was in August 2020. And just recently, she remains well with no clinical sign of recurrence, and this is her most recent MRI in May of 2022. The excised histology did show active tumour, so in retrospect, this was the correct decision. But it does beg the question of how do we manage post-treatment residua? In the study I mentioned earlier of 33 patients, 9 had residual disease. Some of these resolved spontaneously, 3 underwent re-excision, and all of this had scar tissue or inactive tumour. 2 had residual masses without progression, and 1 patient had exenteration with active tumour present, as in our case. So in conclusion, although embryonal rhabdomyosarcoma has a survival rate over 5 years of 95 to 97%, patients with a complete response at 12 weeks will maintain that complete response. However, people with residua have a lower failure-free survival rate, and these residual masses should be monitored with serial imaging and excised if enlarging or showing significant activity on PET scanning, with consideration for exenteration in extremely limited cases. Thank you.
Thank you for the presentation. This presentation has quite high number of rhabdomyosarcoma cases, guiding systematic approaches to the disease. This case will be discussed by Dr. Jeffrey Rhodes from the United Kingdom. Please.
Thank you very much, Tim. There's really very little that I can add to Tim's very clear presentation. And what he's really brought out is a problem that is becoming much more of a problem nowadays. We've known about the problem of what to do with the residual mass for a long time, but we're now faced across oculoplastics with the use of chemoreduction, of biologicals, where you get a spectacular reduction in the tumor. And the question then is, what do you do with the residual tumor? Do you only excise the small residual mass, or should we be excising the surrounding skin where the basal cell carcinoma was originally? Because whereas radiotherapy, we accept that all of the normal cells in the high treated area will be killed, and we hope that all of the neoplastic malignant cells will be killed. With chemotherapy and the biologicals, we don't have quite that luxury, because you cannot give such cidal dosage or you'll kill off the normal organism with the systemic chemotherapy. So we have this problem that we may well not be killing all the cells with chemoreduction. And then the question is, it's survival of the fittest. It may only be 1 in a million cells that is surviving the chemoreduction or the biologicals, but that 1 in a million will eventually reappear. And that's fine if you're treating a tumor in a 70-year-old. You'll give them maybe 10 or 15 years of good quality life with less aggressive surgery. But then we move down to middle-aged tumors like lacrimal gland carcinoma, chemoreduction and chemotherapy regimes. We may give them 10 years more of life, but we may not actually cure them. And the problem is even more so when we're dealing with pediatric soft tissue tumors, where obviously recurrence in their teenager and their 20s will become more significant. And so it really is a very difficult thing to know what to do with the residual tumor. And, you know, it's likely that there is viable tumor. And unfortunately, histology isn't a great guide. Even when you excise these masses, it can be very difficult to tell. There are often bizarre nuclear forms and cellular forms in the residual tumor. And so, how should we treat the residual mass? Should we watch and presume that we've actually treated all of the significant tumor? Should we excise all of the residual mass? Or should we only excise those when they look close to the limits of what you will be able to safely take out, so that if it's reaching the edge of the orbit, should we say, right, this may go outside the orbit fairly soon, so now is the time to treat it? And I don't think there's any absolute answer to it. And, so the $1 million question is probably with a residual mass, as Tim has shown in that case, take a baseline scan, then do repeat imaging. But the key question is, when do you do your baseline scan? And then when do you do your repeated imaging? There's no hard and fast rules. It's like rhabdos, solitary fibrous tumors. When does one re-image? And what modalities does one do? And when should one intervene? Should you say, let's do a local resection if it's a small mass in the center of the orbit, not involving key structures, try a local resection. If you get recurrence, then do an exenteration. Whereas if it's coming out to the margins of the orbit, should we then say, right, this is our last chance to clear it surgically, do the exenteration? I don't know the answer to that. I don't know how often we should be imaging, but these are some of the big questions being brought out by chemoreduction and the sort of pre-surgical modalities being used. So I leave you with more questions than I have answers. And thank you, Tim, for a really good presentation of a difficult topic. Over to Uli and Kyung-min.
Thank you, Jeff. As always, there are, even in your questions, Jeff, there are always answers. But we do have some, and I'll raise them right away because it's on the top topic. There's a question from Prasad about, and that is also, I think, a good question for, did you consider proton beam therapy in this case, and should we add something else than chemo in these recurrent cases?
Sorry.
We don't have easy access to proton beam in Australia, but it was considered. And as far as imaging with Jeff, we do a protocol of we image on a 3-monthly basis using MRI and using PET scans. And with the MRI, we're quite interested in the DWI to look at restricted diffusion. And we will only intervene surgically if we have an increase in the size of the lesion, if there is ongoing growth. And this is a very small number of tumours over a 30-year period. This case is an unusual case.
Yeah, I think, Tim, that's the point. DWI, though, really is sort of indicative of restricted diffusion, which, of course, you will see in the fibrotic post-treatment mass. So it's not, it's a difficult one because you're dealing with fibrosis plus or minus a few tumor cells in it. So that really is a difficult one.
Okay, great. Thank you. In the interest of time, I think we will move on. We will have a wrap up later on and can ask more questions. But we will move on, and we'll move on into the night with a bump. So it's David Verity with Bump in the Night. David, please. Can we have David Verity's pre-recorded talk? Yes, there it is.
Good morning and good afternoon, and thank you to the organisers of this joint ESOPers webinar for inviting me to give this presentation. My title is Bump in the Night, Hold Tight, and is given jointly with my colleagues Geoffrey Rose and Axel Petzold from Moorfields Eye Hospital in London. This 25-year-old lady presented with sudden left ocular pain and swelling overnight. She was unable to move her eye properly, and over the following 5 to 7 days, the pain and proptosis both increased dramatically to the point that she couldn't close her eye at all, and she developed increasing periocular swelling and a jelly roll on the eye, as seen clearly on these 2 images taken within days of the onset of symptoms. She described the pain as excruciating, the worst of my life, and she was admitted to hospital. There she was managed with antibiosis and opioid analgesia, with a gradual reduction in her symptoms and signs, and was discharged after 10 days. On this image, one can see the clear reduction of chemosis. Over the following few weeks, by degrees, the chemosis settled, and gradually the degree of proptosis also reduced. Note that at no point did she describe any sinus symptoms, and none of the images identified periocular erythema suggestive of a sinus or orbital infection. By the end of November, a month after her presentation, she felt that she had made a full recovery and that her eye was back to normal, that is, identical to the way she was immediately before the bump in the night. Again, on review 6 weeks later, she remained stable and, in her words, was normal again, even if these images clearly show residual proptosis measuring 5 mm in clinic, hypoglobus, and a large exodeviation. Finally, here she is only 2 weeks ago in clinic. The chemosis has entirely resolved and the proptosis and hypoglobus improved, being subjectively unchanged compared to a year previously. Now, so far I have not given you all the information. Why would a patient consider proptosis normal for her? What was her visual acuity on presentation? What did the imaging show? What actually is the diagnosis? In fact, her story began 7 years earlier in 2015. Until that point, she had normal vision without ocular asymmetry. Over the course of a month, she lost all her vision to no perception of light. She had experienced less pain and swelling than in 2021, but described gradual proptosis and total loss of vision over that period. Initially, she was diagnosed with optic neuritis, but failed to respond to high-dose steroids, and her imaging, as shown here on the right of the slide from 2015, confirmed a radiological diagnosis of optic nerve glioma. At her most recent presentation in 2021, the receiving clinicians, aware of the diagnosis of optic nerve glioma, had considered a malignant transformation of the tumour. So serious consideration at that time was given to surgery to remove the tumour, being presumed to have become malignant. But was the history right for this? Here we see the accompanying radiology from 2015 at her presentation into 2016 when her symptoms had resolved. The image at the top left identifies cuffing of the optic nerve with resolution between October 2015 and January 2016, this most clearly seen by comparing the two MR images. Thus the history suggests that, while an optic nerve glioma was undoubtedly present, the rapid proptosis and visual loss is more likely to have been due to an ischemic insult, with MR imaging charting its resolution over 3 months in parallel with her clinical improvement. Now, her presentation in 2021 is not dissimilar, but was associated with a greater hydrostatic effect in the orbit, presumably due to massive accrual of inflammatory edema in the mid to posterior orbit, and resulting in severe pain, marked proptosis and chemosis. Again, the serial imaging shown here identifies cuffing around the glioma with radiological improvement over the course of a few weeks, and resolution of the mass effect by January 2022. Note the timeline between end October and early January with associated resolution of signs bizarrely is almost identical to the event in 2015. Finally, and to settle any question of malignant transformation, an FDG PET scan in February this year was negative. So, in summary, as in all medicine, we are led by the clinical history. This patient had a severe bump in the night, but holding tight, despite the impressive signs, proved the best approach, and she made a full recovery, was proven not to have had malignant transformation, and thus far has avoided unnecessary surgery. Thank you very much for your attention. Goodbye.
Thank you very much, David, for that very, very interesting case. You said you would hold tight. Well, we'll see what our discussants will say to that. And we now have, if I understand it correctly, Said Peruz. Are you there?
Yes, I am here.
Peruz, sorry, I wasn't quite sure whether you were ready to go, but you are.
I am, yes. Yeah, this is a very complex case that is presented by David. As far as I know, the gliomas, optic nerve gliomas, I don't know of any case of transformation of optic nerve glioma to malignant tumor. They are pilocytic astrocytomas, and they can grow very fast, actually, that there are cases that they grow very fast, but and malignant transformation, I'm not sure about that. This case is, if you compare the MR of 2015 and 2021, is a significant progression of the tumor. And as far as I know, there is no histopathology of this lesion. There is, I mean, yes, an imaging looks like a glioma. Other possibilities, I can't think of that, since that the whole nerve is enhancing. On the images of 2015, there was some places that you could think of optic nerve sheath meningioma. And unfortunately, in one of those images was no contrast given, so we can't be sure. The meningiomas, is possible that they transform to malignant tumors. Meningiomas in general, I don't know of any case of optic nerve meningioma transforming to a malignant tumor. So yes, looking back at this case, that sudden proptosis and chemosis, yes, its possibilities ischemia, but yeah, something else combined with glioma is also possible. Some inflammation is difficult to say. But I wanted actually to ask David whether there is any histopathology of this lesion.
David, are you there?
Thanks very much. Thanks very much indeed, Diego. All good points. No histopathology. I think the radiology was like 99.9 likely to be a glioma, and clinically she was completely stable between 2015 and 2022. Sadly, she'd already lost the vision, but there was clearly, we weren't dealing with a progressive pathology other than this sort of ischemic infarction, which appeared to have occurred on 2 occasions. The question as to why she would have had an ischemic infarction, I'm not too sure, because she clearly didn't have a rapidly progressing mass effect, except for that induced by the edema itself. That's an unanswered question. And I think the point of the story here is to bring out the fact that she came to see us really for a second opinion. She was about to have surgery a day later. And the question is, what was the history? How quickly was it? And look at the previous scans. And I think with that in mind, it was completely obvious she was having a rerun of her previous event, and literally was 24 hours away from having fairly major surgery, which she clearly didn't need at all. And I think it was just the point that she'd got a lot of different opinions, but quite often a conservative one, waiting and gathering the data is the best thing before charging in a young lady with surgery, which would have been entirely unnecessary. And I think that was the point of it. I'm not sure if anybody else has seen this before. I think Axel Petzold has seen 1 or 2, but basically she had a bottleneck effect at the posterior orbit due to the ischemic edema. And I think that's what ultimately settled to the point where she really was as good as she was before she started. And I saw her 2 weeks ago, and she was identical to the way she was a year or so ago. And other colleagues such as Neil Miller had seen them as well. But also be very aware of a patient who gets too many different opinions, because they tend to be pushed into a surgical cubbyhole if they're not too careful, whereas sometimes a conservative approach is better.
David, thank you for your comment. Farzad wants to comment on that really desperately while I'm trying to keep the time.
Yeah, sure. Very quick comments. Actually, I've seen cases with meningioma and sudden expansion of the tumor, proptosis like compartment syndrome, central retinal artery occlusion. And after biopsy, it was shown to have myxoid degeneration in the tumor. So myxoid degeneration, very rare in meningioma, but happens. It doesn't mean it's malignant transformation. So I reviewed the glioma, and I found very rarely glioma may show actual metaplastic and mixed degeneration as well. So hypothetically, this case may be something like a acute mixed degeneration of the tumor. And we have seen cases with glioma and NF1 actually. Thank you very much.
Sorry, can I say something?
Yeah. All right.
Yes.
Okay.
David, another question is that diagnosis or the first presentation of this tumor was in 2015. Was that at that moment the patient was an adult, or what was the age of the patient?
So at that time she was in Oxford University, about aged 18.
So this is
so she was young, and I think going back through the notes, there had actually been some slower decline in the year leading up to that point. But then she had that acute event in 2015, and that's why she had all the imaging.
Yeah, so probably
but she obviously had something going on from about the age of 18.
Yes,
or even younger.
Very quick.
Younger,
So
but the first acute event was in her when she was 18, just at the end of her term at university.
So she was a young patient when it started, and we could go on that. I'll just wrap up three comments from the chat. One is the dototatu PET to differentiate, and I don't know whether you've done that actually. A possible perineuritis, and instead of inflammation, could there be a venous outflow problem? But David, if you could, really shortly comment on that, because I really want to hand over to Kyung for the last case.
Yeah, thanks very much. Actually, I'll address it because I looked after her originally. She clearly presented back in 2015 with an overnight onset of gross inflammatory symptoms. So this wasn't a mild perineuritis. This was an explosive onset of inflammation. And at that time, it showed an infarcted optic nerve, a very large nerve that had infarcted and which didn't enhance properly in its middle. And that resolved over the months. And then she remains stable, as David said, for about 5 or 6 years, and then presents with exactly the same phenomenon again. And so there's been no indication that this is a nerve sheath. I can't remember whether she had dotatate scan, but always it's been that the nerve is enlarged, not the sheath. So it is a nerve pathology. And as for the sort of myxoid change, probably most myxoid changes in the neurilemomas and the gliomas is due to infarction with a secondary change within them. But, as I say, interesting discussion, and there's been no indication for biopsy because it's a non-invasive process and it seems to settle down.
Okay, thank you very much for all the discussion about this. We will move on. I hand back over to my co-moderator, Kyung, for the last case.
Okay. Next talk is a baby with a unilateral proptosis. It will be delivered by Dr. Rachel Coleman from Netherlands. Please.
Good morning, everybody. I would like to present to you a little girl with a unilateral proptosis. There are no conflicts of interest. So we saw a 7-week-old baby with a mild proptosis of the right eye since about 10 days. Pregnancy and birth were uneventful. She didn't seem to have pain, and there was not an increase in proptosis when crying. On examination, we saw indeed a mild proptosis of the right eye. The lid aperture was a little bit smaller on that side, but otherwise there were no abnormalities. On this slide, you see the obvious but mild proptosis on the right side. We decided to make an MRI, which is shown here. This one is without contrast, and you can see a T1 hypo-intense intraconal mass and a hyper-intense mass on T2 with some flow voids. On this slide, you see the MRI with contrast. which shows strong enhancement of the interconal mass. So regarding the history, the clinical examination and the MRI, we were rather sure we were dealing with a vascular anomaly. The classification of the ISSVA makes a difference in vascular tumors with a proliferation of endothelial cells and vascular malformations without proliferation of endothelial cells. In case of this girl, we were dealing with a benign, slowly growing tumor with MRI images post-matching with an infantile hemangioma. Differential diagnosis consisted of a venous malformation and a lymphatic venous malformation. On this slide, you see MRIs of these two vascular malformations. On top, you see an orbital lymphatic venous malformation with a typical fluid level, and below you see a venous malformation, typically round and with a hypo-intense pseudocapsula. Of course, other serious diagnoses should be considered because they need another approach. First of all, a rhabdomyosarcoma, which most of the time grows much faster. On CT, you see the typically homogeneous soft tissue mass, isodense to muscle. Also, metastasis of Wilms tumor and Ewing sarcoma or a chloroma can occur in the orbit of children, but they look quite different. So back to the infantile hemangioma. This disorder needs to be seen by a multidisciplinary team consisting of a pediatrician, a dermatologist, and an ophthalmologist. Association with Fakey syndrome, in which a large hemangioma is associated with several systemic abnormalities, should be ruled out. Nowadays, the treatment of choice of infantile hemangioma is atenolol. So that is what we did with our little patient. And this is how she looked after 3 months of treatment with atenolol. After 1 year, we stopped and no clinical signs are left. So the learning points of this short presentation are that the diagnosis of this vascular tumor is made on the very young age of the patient, the slow onset and growth of the tumor, with relatively mild signs combined with the MRI images. And the approach must be a multidisciplinary one. So finally, I have some questions for the panel. Would you have done a biopsy in this case? And what is the difference in therapy between infantile hemangioma and lymphatic venous malformation? And what therapy do you suggest for complex cases, for example with bony overgrowth?
Thank you for the presentation. This is a well-diagnosed and well-treated case. This case will be discussed by Dr. Yuan from Hong Kong. Please.
Hello, everyone. I'm Hunter Yun from Hong Kong. First of all, I'd like to thank the organizers for the kind invitation. And I'm going to present the case that was just presented by Professor Rachel Carmen. The case presented was a case of a pure orbital infantile hemangioma with no cutaneous component, showing good response to beta blocker. Now, I think the case is well managed. I think there is no need for biopsy. And I'll discuss a little bit more about the management of infantile hemangioma, including the management of the more complex cases. Notice that we have to differentiate congenital hemangioma from infantile hemangioma. Infantile hemangioma is more common, but it occurs a few months after birth, as shown in this yellow line. Whereas congenital hemangioma will appear right after birth. Congenital hemangioma is further subdivided into 3 subtypes. Other than the differences in clinical behavior, these are differences in the molecular level. Infantile hemangioma is positive for Group 1 marker, whereas congenital hemangioma is negative for Group 1 marker and positive for GNAQ and GNA11 marker. With regard to the diagnosis of infantile hemangioma, if patient is having a cutaneous lesion, then the diagnosis can be made on a clinical basis. We are all familiar with the strawberry needles. For deep-seated lesion, nowadays the preferred investigation of choice will be the MRI scan. A typical infantile hemangioma will appear intermediate signal on T1 weighted images and hyper-intense signal on T2 weighted images. And this will be highlighted by the injection of a gadolinium with a fat suppression technique as shown in this series of images. So should we treat or not to treat? We have to be familiar with the typical history. Infantile hemangioma is a biphasic disease with an initial proliferative phase followed by an involution phase. By the age of 4, 40% will have a complete involution, and by the age of 8, 80% will have a complete regression. And the factors considered, including the age of presentation, severity, location, or the possibility of a visual impairment. And in the periocular region, it's more likely to treat because of the possibility of a visual problem, cosmesis, and also the treatment is relatively safe and effective. The treatment will be a medical treatment, and the beta blocker is very effective. And usually, beta blocker will be given in oral form, and topical or gel form may be indicated for the superficial lesions. People has also tried the intralesional or intravenous form as well. Usually, we will work with a pediatrician after cardiac or pulmonary evaluation. In the old days, we have been treated these cases with intralesional steroid injection, but nowadays this is no longer preferred because of a risk of CRAO from the embolization of the steroid material. Other form of treatment, including systemic steroid, immunomodulator, or steroids, is less often needed nowadays. This is a case, deep-seated hemangioma treated with oral propranolol by us, showing a good response. Surgery is usually not required because most cases will regress after medical treatment, and excision is only reserved for those cases with incomplete regressions. This is a case, incomplete regression. By the age of 8, we have debulked the tumor. Remember, in the periocular region, it is very important for us to correct the refraction and treat the amblyopia as well. For the management of complex cases, a multidisciplinary approach is required. Usually, it's an initial medical treatment, and we try to defer surgical treatment. Embryopic treatment is required in the periocular region. My experience is that for infantile hemangioma, it's uncommon to be associated with severe bony changes. For those lesions, high flow lesions such as AV malformation, these are more likely to be associated with a progressive deformity as well as a bony deformity as shown in these pictures. For the management of lymphatic malformation, if this is a macrocystic malformation, then we nowadays will treat these patients with sclerotherapy as shown here. Whereas for microcystic lymphatic malformation, surgical resection may be needed. So that's all I want to share. Thank you very much for your kind attention.
Thank you. All the questions raised by Dr. Coleman was responded by Dr. Yuen. Is there any other comments or questions? If there isn't, then we'll go to next session. Why don't we wrap up the session?
Yes,
Yeah.
that would be
Dr.
Gustavo's task
Thank
to
you.
wrap it up.
Many thanks to great topics and discussion. The first topic by Tim Sullivan, recurrent rhabdomyosarcoma, a very rare and challenging event. It seems that despite the high recurrence rate reported, until 30%, it can be taken that most of them are residual non-malignant scaffold, but unfortunately, exenteration is still now a common choice in progressive disease. David showed us a typical optic nerve, suspected optic nerve glioma-related vascular event, and the optic nerve swelling due to a vascular event is a very rare case, more frequently malignant or aggressive glioma of the optic nerve may be confused with the acute vascular event due to the similar clinical picture. And David said to us that MRI images and above all response to medical treatment can rule out malignant evolution and to avoid more invasive and unnecessary surgery. And the last case by Rachel, the infantile hemangioma should be differentiated by congenital hemangioma, non-evolutive and GLUT1 negative, and by lymphatic and more complex vascular disease. And the infantile hemangioma has a bi-phase evolution and usually is regressive within the age of 8. And in some case, the medical treatment, mainly the medical treatment, may be considered according to the severity of the disease and the visual impairment. We shall now come to the next session, the trauma and lacrimal. I leave the word to Ganga Sandar. I will thank the moderators and speaker and discusser.
Hello. Thanks, Gustavo. That was fantastic. I thank everybody for hanging on till the last session. We've had great cases, great presentations, great discussions, and a wonderful keynote lecture. It's my pleasure now to introduce two stalwarts in our field. Dr. Hirohiko Kakizaki from Aichi, Japan. He's really a big man, both professionally and personally and physically. And I respect him a lot for his academic contributions to oculoplastics. And Dr. Dan Ezra from Moorfields, England, who will be moderating the session on trauma and lacrimal. Over to you, Dan and Hirohiko.
Thank you, Ganga, and thanks to all the chairs and organizers for putting together such a well thought out session. I'd just like to again start by emphasizing that this is intended to be interactive, so please keep the questions coming through the chat box and we'll try to get to those a little bit later. So we're going to start by inviting Dr. Mutmania Mahyuddin from Indonesia, who's going to give a talk on complex pediatric orbital trauma.
Assalamualaikum warahmatullahi wabarakatuh. Greetings to all professors and doctors. My name is Mutmainnah Mahyuddin from Indonesia. And first of all, I would like to thank Dr. Ganga and the organizing committee for the opportunity. And today I would like to present our take on vision-threatening injury and orbitofacial fracture. I have no financial interest, and I would like to thank Dr. Ira Yunia and Dr. Hisar Daniel who've helped me preparing this case. So let me begin with a case illustration. Our patient is a girl 12 years old who were involved in head-on motorcycle collision and was without helmet. We could observe patient's bilateral periorbital swelling with left eye looked slightly hypertropia and anophthalmic. Visual acuity of the left eye is hand movement with amoretic pupil, and right eye was within normal limit. On further examination, there was limitation of eye movement to supratemporal, temporal, inferotemporal side, and we found pre-retinal hemorrhage anterior to the optic nerve with pale-looking fundus and decreased macular reflex. CT scan revealed bilateral, complex, moderately displaced orbitofacial fractures with entrapment and without foreign body. As seen in this 3D CT scan, the fractures are in accordance with the fourth fracture, type 2 in the right eye and type 3 in the left eye. Patient was stratified as non-high-risk patients from A, B, C, D, E, F, G, H classification. This is the axial section where we could observe there's also fracture of the lateral orbital wall as well as suspicion of optic nerve avulsion of the left eye. We assessed the patient with bilateral optic neuropathy with suspicion of avulsion of the optic nerve and pre-retinal hemorrhage with Berlin's edema of the left eye. We supportive medication to this patient. And as for the fractures, because the clinical condition and the CT image of the right eye shows good fractures bone alignment, we only do repair for the left eye, teaming up with our ENT colleagues. So these are the intraoperative pictures. We assess the orbital walls through subciliary incision, and then the next step is to release the entrapment of orbital content, then align the fractured bones back into the normal plane and place the orbital floor implant. We also put plate and screw for the lateral orbital wall to the anterior maxilla, and the fractured bones were also successfully placed back to the normal alignment with the help of transmaxillary access by the ENT team. So in this case, we put rigid fixation to repair the facial buttress, and we put bioresorbable our choice because naturally in children, the facial bones are still growing and we wouldn't want the implant to restrict or modify the path of the facial development in order to minimize long-term complication. This type of implant will be resorbed within 12 until 15 months. However, the type of implant is also considered expensive. In 1 month after surgery, we could see dramatic improvement of the eyeball position and no restriction in ocular movement. Visual acuity remains the same, but however, there was tractional retinal detachment from peripapillary region to all regions with pale retina. This was just last week, and our retina colleague planned to perform vitreoretinal surgery for the patient. In dealing with patients with orbital facial fractures, clinical judgment prior to surgery is imperative. We need to keep in mind anatomy of the orbit and connect it with the possible pathophysiology happening in our patient. A good surgical strategy, knowing and recognizing the indication, using the right tools or implants intraoperatively, and know what to observe or expect in the follow-up is mandatory. Patients' education and counseling is also important to level with patients' expectations of the surgical outcome. While visual acuity may not improve, yet disfigurement and the risk of having oculocardial reflex should be prioritized. So closing my case today, I would like to discuss a few points with the panelists, such as in trauma patients with both globe injury and orbital fractures, which do we prioritize on their repair, and any experience or suggestive management for the suspicions of avulsion of the optic nerve. Also regarding the approach to orbital facial fractures in children, what is the best timing for surgery and what to observe if the chosen option is to postpone the surgery. Is there a special consideration to these? And maybe the last one is regarding the panelists' experience with implants in orbital fractures. So thank you very much for your time and attention. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Mutmainah, for that fascinating case. Lots of interesting points to discuss. I'm going to hand over now to Vladimir Kratky from the Czech Republic, who is going to lead the discussion on this case.
Thank you. Can everybody hear me? I can't remember whether I turned on my microphone. Yes, perfect. So first of all, I'd like to thank you, as everybody, to the organizing committee about setting up an amazing symposium yet again, and also for personally inviting me to be a reviewer for one of the cases. It is really an honor. What Dr. Nina presented is an amazing case of high impact trauma, which resulted in bilateral orbital fractures and including some collateral damage to the soft tissues of the eye with prolapse causing restrictive strabismus, as well as optic neuropathy. So I kind of took her questions and kind of molded them into a talking point. So I'm not sure if we can see the PowerPoint slide that I made. I only have 2 slides, and the first one is sort of the points that I'd like to speak about. The first one is really a question about prioritization of surgery in orbital trauma. Number 2 is management of traumatic optic neuropathy in this case. I don't think it's up yet, eh? No. Did you want me to just screen share or?
Slides? Can you share your own slides, Vlad?
Okay, share my own slides, okay. I'm not sure if it's gonna work.
Farzad, you may have the slides with you.
I uploaded to the Dropbox as a, you know, we probably don't need the slide. It's just a bullet form of those 4 points. So number 2, oh, there we go. Yeah. So this is page 1. Yeah. So number 2 is management of traumatic optic neuropathy. And in this case, the optic nerve head avulsion. 3 is timing of orbital fractures with respect to children, and then selection of orbital implant. Of course, each of these topics could be an hour lecture, so I'll try and do brief. Well, principal goals of trauma management is after exploration and making the correct diagnosis, you have to also use decontamination of the area and plan your the surgery accordingly. It is based on the degree of bone displacement, how much herniation and entrapment of soft tissues there are, and also how that results in a functional deficit and any collateral damage to the orbital contents. And last but not least, of course, is the cosmetic deficit as well. So let's look at point number 1, prioritization of surgery. I think the easiest way is to look at what is the most urgent thing to look after. As we all know, it is the ruptured globe that we'd have to rule out and look after first if it's occurred. Number 2 would be direct traumatic optic neuropathy. And in this category, I mean, if there's obvious damage or event that can be reversible, such as a hematoma or displaced bony fragment impinging on the octave nerve that could be operated on. Indirect traumatic optic neuropathy does not have a surgical solution, unfortunately. Thirdly, orbital compartment syndrome, even with fractures, it can still occur, and that should be assessed, and it will be another indication for immediate surgery. And especially with floor fractures, we all know about the white-eyed blowout fracture, where we have a trap door kind of a mechanism which impinges tissues, including the inferior rectus muscle, which can also cause ischemic damage and needs to be operated on. Lastly, it can also lead to an ocular cardiac reflex, which can also lead to problems and needs to be addressed. And the very last, if there's a foreign body, we always have to keep in mind that there could be a foreign body that's occult, and we have to look for it, and those may need to be removed. So all these 5 or 6 points is when we do surgery on an urgent basis, which means either immediately or as soon as possible. Next, we look at how much displacement or herniation entrapment there is from the fractures. These may result in functional deficits, such as in this lady, it was movement of the eye, restrictive strabismus, or certainly a cosmetic defect of the facial skeleton. We can look at simple fractures and complex fractures, but all of these have to be assessed with the same lens. If most of the significant cosmetic deficits are due to complex fractures, such as the zygomato-maxillary complex fracture, nasal orbital ethmoid fracture, cranial orbital, or orbital facial fractures, which need to be addressed. There's overall a great variation of timing for intervention with different centers, but in a nutshell, this is what most people will do. I already mentioned the urgent cases, and the timing is, of course, as soon as possible when you can book an OR. Complex ZMC or NOE fractures, cranial orbital fractures are done with about a week. You give it a few days of the swelling to settle, and then you operate. Some centers will stretch it to a little longer. When it comes to simple fractures, such as standard blowout fracture, obviously excluding the green stick, it's within 2 weeks in most centers, but again, especially in the States, they often stretch it to further longer, such as 4 weeks. And Don Kikawa published an article that even up to 6 weeks, secondary intervention can have the same results, and it is very center dependent. The other factors to consider are coexisting injuries and trauma to the rest of the facial skeleton, because if the plastic surgeons or maxillofacial surgeons are taking the patient to the operating room, you might as well join them for your part. So all these factors come into play for the timing. Moving on to point 2, management of optic nerve head avulsion, which is really a subset of the traumatic optic neuropathy. Unfortunately, avulsion of the optic nerve head doesn't have too many treatment options. It usually results from a blunt or sharp trauma, which an object that comes between the eyeball and the orbital wall, causing rotational or attractional shearing forces on the optic nerve as it inserts into the globe, with often breakage or tearing of the axons within the nerve, but leaving the nerve sheath intact. And that's why we can sometimes get fooled when we get an MRI or a CAT scan. It can look like a normally optic nerve, but unfortunately, the patient has lost vision. A better test for this is either a OCT or a B scan, which can show cavitation of the optic nerve head, and lastly, a VEP, just to measure the function of the nerve. So it's a combination of clinical diagnosis with fundus exam and these other tests. Other than supportive measures, we don't have a treatment. It sort of falls into the realm of traumatic optic neuropathy. There was a study a few years back looking at international, it was called International Optic Nerve Trauma Study, which pretty well definitely showed that steroids, even high-dose steroids, do not really have a role in this disease. And I think it would also apply to the optic nerve head avulsion. Let's move on to timing of orbital fractures for children. Again, there's two main points to consider. Number one, as I mentioned already, is the so-called white eye blowout fracture or green stick fractures, which is due to the fact that at this young age, the bones are not completely ossified, and there will be flexible component to the floor where if it's broken with prolapse of tissues, it'll snap back. It can also result in ocular cardiac reflex, and in this case, surgery needs to be done as soon as possible to prevent permanent damage to the inferior rectus muscle. The second factor to consider is orbital growth. From many studies, it has been shown that by the age of 7 or 8, the orbit has grown to about 90% of adult size. So anybody above that age, we can consider it like an adult orbit, but below that age, growth needs to be taken into account. There is different plating systems that we can use. Some of them are permanent, some of them are resorbable. And the thinking is, or the theory is, that in younger patients, we could use resorbable systems, which makes complete sense. If you don't have it in place, then you can use permanent one with secondary operation where you take out the screws and plates so that the orbital growth can proceed. If it's a simple floor fracture where you just put a little piece of sheeting, whether it's silicone or Medpor material, and it's not screwed in, and then you probably don't have to do anything because the orbit will grow and the sheet will just sort of slide in place and not interfere with the growth. The next point was selection of orbital implant material, and there's many different types nowadays. Of course, the ideal implant is something that's stable, allows good fixation, can be contoured or comes pre-contoured, easy to handle, is biologically friendly, and also has a low cost and easy availability. There probably is not an ideal example of this, but there are many choices still. The main decision, again, as we mentioned in children, is permanent versus resorbable, and you can use alloplastic versus autogenous. It depends on the size of the fracture and displacement and age of child. What we use in our center, we use mostly for most simple fractures, we use either Medpor sheeting, which is porous polyethylene. It actually can be molded in warm water to give it a little bit of a concave shape, depending where you put it. If the fracture is larger and needs more stability, then I like personally the Titan implant, which is a composite implant with titanium mesh embedded within polyethylene sheeting. And it can be certainly cut to size, and the stability is achieved by using the screw holes to screw it to the anterorbital rim. And it's perfect for large fractures that do not have a supporting edge on the outside within the orbit.
Vladimir, we're overrunning terribly. Yes. Could we perhaps just wrap this up quickly?
Okay, we can, for sure. Just on my last sentence, sorry. If needed, then we can use RapidSorb, which is a resorbable implant, or the alternatives I mentioned is to use a regular one and take out the hardware in about 6 months. And that pretty well wraps it all up. So the timing was perfect. And I'll be happy. Again, thank you very much for allowing me to participate, and I'll be happy to answer any questions.
Thank you, Vladimir. I don't think we have any time for further discussion. Perhaps at the end of the section, Gang, if there's time, we can come back to this. But otherwise, I'm going to hand over to my co-moderator, Hirohiko Kakizaki, who will take things from here.
Thank you very much. So this is the final session of this meeting. The topic is lacrimal disease. So the speaker is Dr. Adriana Luriano, and this is a pretty good talk. Please start.
Hello, everybody. It's a very pleasure to share with you a very unusual case of pediatric daclyocystitis. A 5-year-old boy referred to our unit with a 10-day history of fatigue, lack of appetite, diarrhea, associated with eyelid edema, redness, epiphora, with mucopurulent secretion in both eyes. His brother died at 2 years of age due to fulminant Epstein-Barr virus-related hepatitis and signs of lymphohistiocytic activation. Clinical history revealed an infectious mononucleosis 3 months earlier. The provisional diagnosis was acute bilateral daclyocystitis. This is the patient. Clinical examination showed a normal psychophysical development. Visual acuity anterior and posterior segment exam was normal in both eyes. There were palpable masses of soft consistency at the lower eyelids, and there was a regurgitation on pressure of lacrimal sac with small yellowish concretions. No exophthalmos was detected. In differential diagnosis, we considered bilateral acute daclyocystitis, preseptal orbital cellulitis, allergic conjunctivitis with associated bacterial infection, and inferior eyelid infiltration of inflammatory or neoplastic origin. Blood tests revealed hyperferritinemia, hypogammaglobulinemia, hypoalbuminemia, and anemia in the absence of cytopenia. A raised ESR, CRP, and serum transaminases, and a PCR for Epstein-Barr virus DNA was positive. The CT scan of the abdomen and chest showed the hepatosplenomegaly, pleural and pericardial effusions, and focal bronchiolitis and parenchymal thickening. Brain imaging showed the thinning and alteration of the signal of the corpus callosum, bilateral obliteration of the ethmoid maxillary sinuses, and inflammatory thickening of the periorbital subcutaneous adipose tissue, hypointense in T2. The study of the bone marrow showed an hemophagocytic infiltrate with an increased cellularity with focal hemophagocytosis, and an incisional biopsy of the lower right eyelid through a subciliary approach was performed, and an abnormal pinkish brown tissue was identified below the orbicularis muscle. Histopathology showed an atypical lymphohistiocytic proliferation, and immunohistochemical investigation showed a lymphoid portion consisting mainly of T cells, CD3, CD5, CD8 positive, while CD20 expression was present in only few B lymphocytes. All histiocytic cells were positive for CD68. This is the hematoxylin eosin stain. These are the immunohistochemistry and hematoxylin eosin images. And these are the immunohistochemistry details. The final diagnosis was Epstein-Barr virus-related lymphohistiocytic infiltration involving eyelids and paranasal sinuses in a patient with X lymphoproliferative syndrome type 1, confirmed by genetic study. Dexamethasone, anakinra, and acyclovir were started to treat extramedullary lymphohistiocytic infiltration. Rituximab was started to reduce Epstein-Barr virus titers, and upon rituximab treatment, a dramatic improvement of periorbital edema and nasal congestion was observed. Finally, the patient underwent a successful hematopoietic stem cells transplant. The child was not treated with surgery for the dacryocystitis, and a regression of dacryocystitis was observed in treating the underlying disease. And this is the patient after 1 year of follow-up.
Thank you very much for excellent talk. So, Jabed, okay?
Yeah.
Yes. So, Jabed probably has more cases, similar cases probably in the world. So, please start your additional lecture, please.
Yeah. So thanks, Kaki. There's no lecture because I think the allotted time for the discussions are only 5 minutes, and I take my time very seriously. So with regard to the case, Adriana had asked a few questions, which also talked about pediatric external versus endoscopic DCRs. Let us not get into those aspects of it. Let us just focus on this particular case. So, these pediatric acute dacryocystitis, these I call them as special infections, those that have, say, dacryocystitis with Pantavia species or Sporothrix shenkai or Epstein-Barr virus for that matter. And if you look at the literature from 1990 to 2022, the 32 years of literature, to the best of my knowledge, there have been only 7 cases reported of such a happening. Though I'm sure there may have been many more else. We just, I think one of our papers or a similar case is under review for Epstein-Barr virus dacryocystitis. Now, if you look at those 7 cases that were published, most of them were bilateral. So, so this case fits into that thing. I think 2 were preseptal cellulitis, and all of them had secondary bacterial infection. And all of them tested positive with the Paul Bunnell test, the erstwhile monospot test, not very frequently done nowadays. But, in those days, it used to be done. And then most of them resolved without a sequelae. And that's a very typical feature of Epstein-Barr virus. Now, when a patient with an acute dacryocystitis, bilateral dacryocystitis, comes to me with a history of recent onset pharyngitis and cervical or preauricular lymphadenopathy, that's the time when I suspect a special infection. And most of those times, it's this kind of viral that comes out. Now, the pathogenesis why this happens is that Epstein-Barr virus has a very typical affinity to tissues which have mucosal surfaces which have lymphoproliferative tissue under the submucosa, like the nasolacrimal duct. So it causes infections of the nasolacrimal duct epithelial cells, and obviously targets the resting B and T lymphocytes in the lacrimal drainage associated lymphoid tissue. And that causes a massive swelling in a very short period of the nasolacrimal duct and causes a typical acute dacryocystitic retention like syndrome. So what happens is that acute dacryocystitic retention happens, and then the secretions get retained into the lacrimal sac at a very acute rate, and then secondary infection happen, and then the cellulitis and the sequelae happens. So practically, if you do not treat these patients or just have supportive treatment, which most of them receive because of the fever and pharyngitis, most of them resolve and the lacrimal drainage issue subsides, even if lacrimal drainage, the lesion appears like a lymphoproliferative mass lesion that involves the lacrimal sac and nasolacrimal duct. It resolves very beautifully without any sequelae. Why this particular patient, the previous sibling, died is because in certain cases of Epstein-Barr virus, those who have the X lymphoproliferative syndrome, the response of lymphoproliferative tissues of these patients is very massive to Epstein-Barr virus, which is not the case with most of the people. I'm sure all of us have some time of our lifetime have got infected with Epstein-Barr virus, but it just comes and goes off. But this patient being X lymphoproliferative syndrome, this is not unusual to respond like that. And sometimes these kind of children usually die because of sudden splenic rupture. That is what I think might have happened in the previous sibling. Yeah. So I think this is something that you need to report, because there are very, very less number of cases
course.
in that one. And this is something that most of the cases, if you find, it just don't do a DCR in these cases. That's the point.
Okay, thank you.
Thank you, Hirohiko. Any comments from your side before we wrap up?
No, I have no comment, but probably Adriana have some comment to this Javed's comment.
Yes, thank you, Javed, for your comments. I know that this is a very unusual case of a pediatric dacryocystitis, and I think that we will report in literature this case.
Thank you.
Thank you, Javed. So in 7 cases, how many cases do you experienced?
I experienced 2 of them actually.
2.
Oh yeah.
Too much.
If you see 70 lacrimal patients in one OPD, you are bound to see that.
Oh, too much. Thank you very much, Adriana and Javed.
Thank you.
So, yeah, the Ganga, please.
Thank you, Hirohiko and Dan Ezra, for moderating the session. Thank you for the case presentations and the lovely discussion by Vlad and Javed. We are about half an hour over time, so unfortunately, we'll have to cut the discussion short. And Professor Tim Sullivan from Brisbane sending me subtle cues with his nightcap in his hand and his pajamas he's wearing. We are running late. So may I, before we close the session, the entire webinar, invite 2 of the wisest people in the crowd, both Professor Jeff Rose and Jim Katowitz, to make a few comments about the entire webinar before we come to a close. Mr. Rose.
Well, what is there to add, really? I think we've been through so many things and learned so many new things. Like the last case, I'd never seen one like it. But as soon as you hear the brother died from fulminant EBV infection, you think, there's something wrong with these kids. But across the board, we've had other cases of SCID and so on. Fascinating. There's always something to learn. So thank you, everybody, for what they've done. And how can you summarize the increasing pool of knowledge? But thanks to all who've organized this and to people who've hosted it. Thank you.
Thank you. Dr. Katowitz? You're muted.
Mute. I certainly would echo what Jeff has said, but I think it's remarkable to have covered so many interesting cases. The collegiality among everyone is a wonderful thing to observe and to share. This is the most important thing we can do in this world of conflict, to really be able to enjoy the talents and the humanity of everyone. So thank you so much for the opportunity to share this with you.
Thank you very much. With this, I hand over 5 months' work back to my co-chairs, Dr. Eva, Dr. Gustavo, and Dr. Farzad, the great organizer. Over to you, Eva.
Thank you. I'd like to thank all of the wonderful faculty for sharing your huge knowledge today and for the participants being with us. The pandemic led us to arrange more of these webinars when we could not travel and meet in person. But this was not actually just a disadvantage, but also better possibilities to include many of you oculoplastic worldwide stars in one meeting, which we have managed today. I would also like to express my great thanks to my co-organizers, Farzad, Ganga, and Gustavo, and for Iravo for hosting the meeting on behalf of ACT sufferers. And I would hope to see you face to face in Nice at the French Riviera in September, when e-sufferers are celebrating our 40th anniversary. Hope to see you there. Thank you so much for today. Bye-bye.
Thank you.
And
thank you. Bye. Thank you.
Bye-bye.
Thank you, everybody. Thanks, Daima.
Bye-bye.
Thank you.
Thank you.
Thank you. Thank you, guys.
It was a pleasure.
Thank you. Bye-bye, guys. Have a good
Great
weekend.
meeting.
Enjoy.
Thank you. Well done,
Have a
everyone.
good day.
Thank you.
Sayonara.
Thank you. Thank you.
Auf Wiedersehen.
Have a good day sometime. For some other people, good night.
Ho, ho. Ho, ho, ho.
안녕히
In
가세요.
Italy, we are close to the lunchtime.